Good morning. I want to welcome this huge crowd to Friday morning conference. I want to remind you of if you want CME credit for doing this, you don't get it just by coming and signing a piece of paper. You have to take one of these little slips of paper, and all information about how to sign in and do it is on there. And once you've done it once, all you have to do is sign on, and it knows who you are. And it's very simple. Each week's worth takes about a minute. You just push little buttons. It's just like taking the national boards again. Oh, okay. This is the last conference in the Ethics Month series. And there are 3 more Friday morning conferences, except there's only 2 because next week there won't be a Friday morning conference. And but the last one is the 20th of May, and then we break for the summer. You're used to me introducing speakers, but I'm actually the speaker today. And I said that I wanted to introduce myself. Does it sound okay? I wanted to introduce myself because what I'm going to talk about is tied into my own story, and it makes it more interesting. I have a background in philosophy, but I am not a philosopher. I'm not going to lay out a whole bunch of esoteric stuff for you. And most of you, I think, know probably everything I'm going to talk about. I'm just presenting a way of pulling it all together and talking about it, which when we get to the end, you'll see where I'm going with it. I've tried to tie it into some of the other earlier talks, especially to Dr. Stone's talk on the inequities in healthcare. So we're going to talk about the right to health and the right to health care, which are 2 really very different things. We sort of throw them around in our culture like they were all the same thing, but they're really not. You got to get used to looking that way instead of that way. The objectives here are to understand what we mean when we talk about rights, because it's not nearly as clear as people pretend it is. Give you a very brief history of where the concept came from, and I'm hoping when we're done that you will be able to talk about everything that I'm going to talk about better than I am. But as I say, it's a really huge topic. Reams and reams of literature. So don't get mad at me if I blow over something too simply, and when we're done you can interrupt me. And I got involved initially in this as an undergraduate and a master's student in philosophy and ethics, not specifically looking at the right to health or healthcare, but rights in general. I was practicing in Oregon in the 80s, and when they adopted the Medicaid system, and Oregon did a very interesting thing. They assembled groups of citizens, and a lot of them all over the state, to talk about what Medicaid should pay for and what it should not pay for. And there was a lot of talk about rationing health care, but it worked. All these groups came up with a long list of procedures of medical things, ranging from going to see your doctor to having bypass surgery, and they drew a line, and they still refer to it as the Medicaid line. It's still there, although the procedures have shifted some. But if what you needed was above the line, you got it. There were no questions. Doctor just sent the bill. If it was below the line, it didn't mean that you didn't get it, but it meant that there was a big review process, and maybe you got it and maybe you didn't. Along the way, I taught philosophy of religion and world religions at the University of Nevada, and then here I taught the bioethics course for a couple of years with Burke Townsend. It's very interesting to teach because you hear the way other people, the way students think about things, which in my case was very different to the way I think about things. Most of my professional career as a physician has been working with the poor. Started a couple of free clinics. When I moved to Montana 20 plus years ago, I had 4 little kids, and I was having trouble getting a job because I only wanted to work part-time. And I ended up at the county jail, which started a long career in correctional health care. I was the medical director for the State Department of Corrections for 12 years, and I'm still a consultant for them. So I've been struggling with, on the street, what are the rights of people to have health care? I think it's really important to talk about it right now because it's a political year. You know, Donald Trump wants to do away with the ACA. Bernie wants to have universal health care. They throw these words around. You know, I think we'd all agree that the ACA is not perfect and it does need some adjustment. But I think it's important that we as health professionals know what we're talking about when people talk to us about it. There's the huge question of how much of the responsibility is the government's and how much of it is that of private insurance. Do we really want the government running all of our health insurance? There's huge confusion about what it means to have a single payer insurance. Again, when I was in Oregon, we had a really nifty system. There were hundreds of insurance companies, but the doctor sent all their invoices to Aetna, and Aetna sorted it out. And if Medicare paid you first and then Medicaid paid you second, Aetna sorted all that out. And the checks sort of came in every now and then. It worked very well, but it was all private insurance except for the Medicaid, Medicare. And involved in this are all of the questions about drugs. If people have a right to health and health care, surely they have a right to the drugs that are necessary for it. There are all the international treaties that involve patents, and those are all tied in with questions about the rights to health care. So what are we talking about here? There are a lot of definitions of right. I like the idea of it as a moral or a legal entitlement. You have a right decreed by somebody or some law to have something. You can also think of it as having a reasonable expectation of having, you know, if you are a person, you should have a reasonable expectation of having enough calories every day. There are negative rights and positive rights. The right to freedom is a kind of positive right. The right to not be tortured is a negative one. Obviously, you can phrase them all in either direction, but it's better, I think, to think of the negative things as the things that you don't want versus the things that you do want. There are different sources of rights. And this is where people, I think, really don't begin to think about what rights mean. You have in like the religious traditions, the concept of persons having some intrinsic right to food or to peace, or there are also rights that are provided by the legal system. That we'll talk a little bit about that. They're both U.S. laws and international laws that play into that. And then there are the socially determined rights. When a society decides that persons have the right to health care, that becomes the overriding reason for the right, independent of how it really got there. Related to rights are obligations. If I have a right to health care, do I have an obligation to do something to obtain it? Do I have to, if I ride my motorcycle, you've all heard this argument, if I ride my motorcycle without a helmet, does St. Pat's ER really have an obligation or a duty to take care of me when I crash? And does the society have a duty to take care of me for the whole rest of my life when I'm a quadriplegic and needing 24-hour care? If I'm obese and my health is affected by that, does that somehow mitigate the duty of the healthcare system to make me healthy? Do I have to be accessible to care? I have a friend with a cabin up in the Garnet Mountains, no cell service. He's a high risk for a cardiac event. But we don't expect cardiologists to hike around in the Garnets looking for patients. You've got to get yourself there. And then you have an obligation to have insurance. And This is a big one now because technically every one of us has to have insurance, but my house cleaner doesn't have insurance. There are a lot of people who still don't have any insurance. So does St. Pat's have some kind of duty to take care of those people who have failed to do what they could have done? Now, there are reasons they didn't do it, and I'm not going to get into that. If someone has a right to something, someone or something has a duty to provide it. It's useless to say children have a right to food if nobody cares enough to provide food, if our society is not set up to do that. In the case of healthcare, this becomes a big conundrum. Is it the government's duty to provide it? Is it private health insurance's duty? Is it St. Pat's duty? Is it doctors? My father was a cardiologist back many years ago, and every Saturday morning he went and did health care for those who couldn't pay for it. And when Medicare came in, he was really opposed to Medicare because we had a system for providing care for the poor. And fortunately, he was not in charge of the national government. And then there's the question of what's the role of the nonprofit organizations. And several of you and I have been involved in that for years, and it's some of our national government leaders over the years have said, well, let the churches do it. We don't have to do it. Or just really quickly try and clarify this. Dogs, wolves, before we domesticated them, had no rights at all. They lived in the savannah or the Yosemite or Yellowstone, where they lived. They were very vulnerable. It turns out that the average life expectancy of a wolf is 3 years. Now that's a little bit like the average life expectancy of someone in Somalia because it's skewed by the death of the puppies. A lot of the puppies never grow up. But even then, being a wolf is dangerous. You get your head kicked in by a buffalo when you're 3 or 4. We take animals in, we domesticate them. Oh, there's now some evidence actually that dogs domesticated themselves, that they learned there were advantages to being in the camp, and they started providing services like barking when the predators were coming in. But be that as it may, we domesticated them. We take them into our homes, and you would say that those dogs have the right to food and be cared for because they can't do it on their own, the way we've set up their lives. And the person who is taking care of them has a duty to provide those needs, for those needs. The dog also has some obligations, though. We expect the dog to hunt or to be a companion or to herd the sheep, whatever it is. And if he doesn't do that, or if he bites children or whatever he does that the owner doesn't like, we don't get terribly concerned about the owner taking him to the Humane Society and saying, this dog doesn't work, you've got to find him another home. We might be a little critical, but basically that's okay. As a society, we don't expect you to keep a dog around who's not doing his part. You may want to. I've had several that didn't. But moving on to other definitions. Health is the hard one to define, and I personally like the World Health Organization's definition. This is a 25-year-old definition now, that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. You can tweak that in a lot of ways, but it's clear that you really don't have a right to health. Health is determined by a whole lot of things, including your genetics, but the real question is there a right to the determinants of health? What John Stone was talking about, the upstream things, food, clean water, sanitation. 47% of persons in India are still defecating outdoors, and the children die from diarrheal diseases related to that. Is that somehow a violation of rights? And then the big one that we now are really clear on is the role of health, especially, or education rather, the role of educating women and providing family planning services and obstetrical care. Makes a huge difference in the whole societal health picture. health care is the really the conundrum. You know, what do we mean when we say, do you have a right to health care? Does that mean that as a society we have a right to all of the services of public health, food, housing, immunizations? Does it mean preventive health care? It looks now like a lot of what we call preventive health care isn't really contributing much to health. How many doctor visits should you be able to get? Emergency care, you know, if you drop into the emergency room, should you be able to get whatever you need? I think everybody would agree you need if your leg's broken, somebody needs to take care of it. But if you're just having a cold, does the emergency room really need to take care of you? Chronic care, the big one now. You know, what level of care does a diabetic really need and benefit from? The concept of readily available care. I have a couple of internists here in town that I see, and it's often 3 or 4 weeks before I can get in, sometimes longer than that. New patient visits are months. Is that a violation of a right, or is that simply a fairly dysfunctional healthcare system? And then there's the big one about the end-of-life care. And I know many of you in the room are tied up in struggling with those questions. And then there's the issue of money, limited resources, and how do we possibly do all the things that people claim they have a right to when we have a limited economic and manpower resources. When the United States is spending 19% of our gross national product and getting lower quality health indices than countries that spend 6 or 7%, you know, something's wrong there. An interesting article in the New England Journal just 2 or 3 weeks ago about whether it's ethical to withhold prevention, and he talks about the QALYs, the quality adjusted life years, the comparing an older woman with stage 4 lung cancer who gets $100,000 worth of treatment versus putting that $100,000 into quality public health services and preventive care. And he's right. I mean, we have to struggle with that. I don't know the answers, but we have to struggle with these questions. Now, like the dog, it's clear that early man really had no rights. He ran around on the savannah, and they had the tribe, and people took care of each other a little bit, but very, very vulnerable. Babies died, so you have the same short lifespans. Thomas Hobbes, who's one of my favorite old philosophers, said that life in the natural state, we talk about natural man and the natural rights of man. Hobbes said natural, nasty, brutish, and short. I think he was right. So where do we get this idea of rights? And it's actually a very late concept. Most society organization up until a couple hundred years ago revolved around what was best for the society. You know, it was not good to have widows and orphans starving from the standpoint of the benefit of the total society. It was not about the widow and orphan having a right to be cared for. In the various, all of the religious traditions, we see this. It's not about rights, it's about duties. Christianity is really very specific about taking care of widows and orphans, and much of the Eastern traditions are a little more on relieving suffering. The religious ideas are based on revelation, on prophets, on holy texts, and they flow from this vision of what the world would be like. What would God like to see the world be? There is an introduction, though, in all of the religions about people having worth in the image of God, or being brothers, being treated equally. And our friend Jesus, of course, said to heal the sick. The philosophical roots are just as recent. The ancient philosophers, and there are some of these cuneiform things, the Law of Hammurabi and the Charter of Cyprus, and that talk about certain basic things that society has to have and that can't be abridged even by kings. And that included things like you can't have your peasants in your fief starving. The first real indication I could find of the use of people having rights is the Muslim philosopher Al-Farabi in the 10th century, who did talk about people being endowed with rights and should live in charity. We get into the 17th, 18th century, into the Enlightenment period. The philosophers started talking about natural rights. Rights, but they're still not rights. They're not the positive rights I've talked about. You have the right to be for protection and just treatment. Even if you're poor and someone steals your cow, you have the right to get some justification out of it. But there's a beginning to be a shift from the government maintaining stability for the benefit of basically the wealthy and the powerful, to the government existing to maintain life for at least all of society, and some emphasis on the poorer side of it. In 1689, the English Bill of Rights was the first actual document of securing rights of people, but still it's rights to petition, rights to be free from cruel and unusual punishment, have your case heard in court. John Locke said that all persons have natural rights, but he didn't really justify why he thought they all have natural rights. But he did the first real clear statement that the government exists to protect the people, and that it derives its authority from the governed, not from the king or the church. In the United States, the First Continental Congress talked about the entitlement to life, liberty, and property. Life, liberty, and property are a far cry from the social determinants of health. We haven't got there yet. The Declaration of Independence is the same thing, that we hold these truths to be self-evident, that all men were created equal, and with certain unalienable rights, among these life, liberty, and the pursuit of happiness. We still haven't got rights defined in a way that I'm comfortable with. Moving on, the 1787 Constitution and the Bill of Rights that we currently are living under, again, was protection from undue government. The United States, from the Revolution on, has been concerned that people not be subjected to too much governmental oversight, the whole thing about the government not being able to take your guns away from you. And it was not really up until about the mid-60s, 1960s, the concepts of people having rights were really not clear. We had slavery, we had all of the racist things going on. Women and children, women couldn't own property, they couldn't vote. That began to change in the 1900s, and workers got rights, they could unionize. We began to recognize that blacks might be people, and we still haven't really got there, but we're getting it. And of course, gays now are at least legally, have the right to do most of the things that the rest of us can. Looking for legal justifications for rights is a very murky, slippery, slidey slope. I would like to tell you that there are very clear laws that all children have a right to 2,000 calories a day. I'd like to tell you that's not true. There is one subpopulation that has the constitutional right to health care, and that's prisoners. The Supreme Court has held that prisoners have rights because they are unable to secure their own health care. And this is where I've really gotten involved with rights, because as the medical director for the prisons, I had to decide whether this guy really needed his PET scan or not. it's not an absolute right. They have the right to have their pain addressed, to see a provider if they're having problems, and to have the orders of that provider followed. Not necessarily exactly. If there's a different drug on the formulary, there's no question about changing it. But if the doctor writes that the patient should be seen in 3 days, he better be seen in 3 days, or there better be a note in the chart that the nurse checked with him and scheduled him for the next day because the doctor wasn't in that day. That's fine. I mean, it's not an exact thing, but it's a fascinating area to delve around in. There's a lot of legal precedent now about disability rights and child abuse, and it isn't quite as bad as it used to be. But it's still, we don't have anything about all of the social determinants of health. International law is a conundrum. I was going to talk a lot about it, and I'm not going to talk hardly at all about it. The big problem with international law is that a country cannot be held accountable for an act unless they have signed on and ratified whichever treaty or consultation set out the right. So, for instance, there is the Consultation on the Rights of Children, which is 25 years old now. Very comprehensive thing about how children should be treated. It has not been ratified by Somalia. Sudan is just working through the process of ratifying it, and it's not been ratified by the United States. The entire rest of the world has ratified. The reason being, there are a number of clauses in it that the opponents feel would limit the rights of parents and the rights of local government to make decisions about children. You know, this is, I'm just the reporter. But the international discussion began in the 1800s because the war scenes, the battlefields, were so terrible. Weapons had been developed that could decimate bodies, and bodies were being left on the field. There's one account of a battle in the Crimean War where there were more veterinarians standing by to take care of the horses than there were doctors to take care of the people. Really terrible situation, and Florence Nightingale stepped in the middle of the Crimean War, pushing for the rights of the injured. In this country during the Civil War, Clara Barton did the same, and actually founded the American chapter of the Red Cross. And they issued a statement about the rights of prisoners and soldiers. And then in 1899, the Hague Peace Conference also had the conventions of law of war, which included the right to put up a white flag and, you know, don't shoot me because I'm surrendering. Which is a huge, I mean, it's like when two kids are fighting, if they don't have a stop word, there's no way to stop the fight. After World War I, the League of Nations was formed. They had a number of statements about rights, still mostly about protecting soldiers, but there was a lot of references to minimal levels of health. The health organization of the League was formed, encouraged very active international public health work. There was still, and especially in this country, the emphasis on non-governmental sources being responsible. After World War II is really when the changes started to happen. The United Nations was formed, has a huge emphasis on human rights. There's a whole, the Commission on the rights, on human rights is big operation with statements coming out every week about rights that people should have. There was when the Tuskegee syphilis experiments were revealed, and people were so angry to know that doctors were participating in these horrendous abuses. In the 60s, the women's health movement came along, the Boston Women's Collective, and the rights of women to control their bodies, to have family planning, to control their births, I was very active in the home birthing movement back then. Well, not in the 60s, but in the 80s. Women were saying, we are people of value and we want to have some control over our bodies. And the whole public health thing really took off. It was recognized how important poverty is to health, how all of the chronic diseases especially are affected by lead paint with children, the pesticides, Rachel Carson's work on the environmental impacts. And then I think mostly because of the availability of international media, we began to see some of the horrors overseas in the underdeveloped world. Americans had never been exposed to that until the pictures, we all know the picture of the little girl after Hiroshima running down the street. Most of us in Missoula, Montana would never have thought that was even a possibility. And now we all know. So there developed a sense of rights. The UN Assembly ratified the International Bill of Rights in '76. It's been modified a number of times, but it really hasn't changed much. Stating, whereas the recognition of the inherent dignity and the equal and inalienable rights of all members of the human family is the foundation of freedom, justice, and peace in the world. Whereas disregard and contempt for human rights have resulted in barbarous acts which have outraged the conscience of mankind, and the advent of a world in which human beings shall enjoy freedom of speech, belief, and freedom from fear and want has been proclaimed as the highest aspiration of the common people. Still no assignment of duty to perform these things or to provide these things, but recognition. Everyone has a right to a standard of living adequate for health and well-being of himself and of his family, including food, clothing, housing, and medical care. This is the first time I could find where medical care was actually included in these rights that people have, and the necessary social services, and the right to security in the event of unemployment, sickness, disability, widowhood, old age, and other lack of livelihood in circumstances beyond his control. That's huge. I mean, it's the disability rights, it's the rights of children, and then motherhood and childhood are entitled to special care and assistance. All children, whether born in or out of wedlock, shall enjoy the same social protection. Unfortunately, I think they've kind of backed down. The latest iteration of the Millennium Goals, the last set of Millennium Goals were completed in 2015, and they weren't completed, but there's really some remarkable progress going on in the developing world. We don't hear much about it because the media wants us to hear about Trump and Sanders, but there really is some amazing improvement going on. The percent of people in total poverty has been halved in the 15 years of the Millennium Goals. But we now have happiness and well-being as universal goals. I'm not sure whether they went to Bhutan and got that, but I have a problem with that one. And aspirations in the lives of human beings around the world. Happiness is neither a frivolity nor a luxury. It is a deep-seated yearning shared by all members of the human family, and it should be denied to no one and available to all. The new Millennium Goals don't say much about health. We want to reduce child mortality some more, and that's actually been in the first set was partially achieved quite remarkably. An improved maternal health, and those are linked. And then we're going to combat HIV, malaria, and other diseases. And for those of you that follow the public health discussion, there's a lot of controversy about the fact that so much money and attention is going to HIV, malaria, and a few other diseases, now Zika, when there's so much other health issues that can be addressed and need to be addressed. But anyway, that's where the UN is these days. So all we really get from the international law is finally a statement that humans have some rights. And I would personally would like to see it sort of extended to the environment and animals. You know, if we have rights, I think all natural creation has rights, but be that as it may. What we do have some guidelines, I think, of what an ideal society should look like, might look like, but there's no rule about what the United States should provide for its people, other than its prisoners. We do that. And it's very difficult to take any abuse of rights except for negative rights to the international courts. You cannot, there's the big court at The Hague, and then there are a number of regional courts. The country being taken to court first has to have ratified whatever agreement it is that you're taking them to court under. And then it has to be really clear that there has been a violation. So we're seeing these dictators and people like that taken to court, but they're really, the big things are things like patent violations. You know, we have all the trade agreements that say that Pfizer can only make this drug for the next 20 years, nobody else can. Those are international treaties that we go to India to enforce, but that doesn't help the rights of humans much. And then, as I say, we don't play very well. I think it would be really tough to sue the United States government for a failure to bargain for Medicaid drugs. I'd like to see them do it for Medicare drugs. But so I think the real question that we have to ask as healthcare providers is whether we really believe there's a right to health care or a right to health. In Missoula, 34% of the persons using the food bank are children. 14% of them elderly. On any given night, there are 35 to 45 families who are homeless in Missoula. And for a vast majority of them, healthcare expenses have contributed to that. The healthcare debt is the leading cause of bankruptcy in the United States. What does that say about what we as a nation and as a people believe about the rights of individuals to have health care? As I said, in India, we have the sanitation problems. There are 25 million refugees right now all over the world living in these godforsaken tent cities that, and we've got a lot of land here. I'm not in favor of bringing everybody here, but you know, we could certainly fight a little less about bringing them all here. And then there's, I think, the question of what we mean by universal health care. We have obstacles, and there isn't the political will. And did any of you go to the president's lecture last night? He was talking about how we as citizens of the United States have to learn again to get politically involved. And gave a lot of examples of things that happened 20, 30 years ago because millions of people got involved. Of course, we've got the insurance companies that really don't, they're doing pretty well right now. The hospital, and we call it the hospital industrial complex, is huge. I have a son in hospital administration, and his clinic program, they have 11 clinics in one town and 8 clinics in another town. They run, you know, all the health care is provided by these people. And it's a nonprofit. You know, when he talks about how much they bill the government for, you know, I don't think so, do I? We all have, there are the problems of lifestyle choices. The incredible obesity and inactivity levels in much of our population. I think the biggest thing is that we don't want to talk about these things. You know? We don't want to talk about the right to life. We don't want to talk about end-of-life care. We don't want to talk about how much health care is appropriate. You know, the whole discussion about 10% of our health care budget going to end-of-life care, people in the intensive care unit when they die. I don't know what's right or wrong, but we don't talk about it. And then it's not about the money. I mean, this is the wealthiest nation in the world. We may think we're going downhill, but we're still way ahead. Hi, Clancy. The New England Journal ran a series starting in January of last year, sort of about once a month they had a different article by a different author about how healthcare is provided in many of the countries that have sort of universal healthcare. It's fascinating. If you're interested in it, I would go back and dredge some of those up. There's Canada, England, China. It turns out these are not universal healthcare provided by the government. We all think about, you're in Sweden, you go to the hospital, you never see a bill. Most of these systems are a combination of private and government involvement. But they have a little column, each has the same story, about a 52-year-old guy who has a heart attack and a 26-year-old primip who's having her first uncomplicated pregnancy. And they describe the care that they get in each society. And it's interesting because they're very different. They all get, the heart attack guy always gets his calf, the woman always gets her baby, but how it gets paid for and the range of services is always different. It's very interesting. So anyway, why am I belaboring all this? Because I think it's important that we, as healthcare people, think about it and talk about it, both within our professional lives and in our community lives. It's not clear what rights are, whether they are self-evident, why we have any rights at all. If we're going to have rights, we have to convince people to talk and ask for them and demand them. And also the rights, we can agree on rights maybe, but then there's always people who disagree. And this presidential campaign, we're seeing that just rampant. I can't believe anybody would vote for somebody who wants to build a wall along the Mexican border. We already got a wall along a lot of it, and I went down there and worked down there and saw that wall and the devastating effects it's having on Mexico. But I think we all need to be involved, and I think as Dr. Stone said, we all have to be working upstream. And sometimes it's hard. You get too much going on in your lives, and we're all too busy. So who's going to argue with me? Somebody can. Well, a lot of you I know personally have been involved in these issues for years. Yeah.
Out loud. Mm-hmm. And like, if you do try to have the conversation, then people just run away or they defriend you on Facebook or, because they just don't want to, actually have an open conversation about hard issues. And then you never know what other people are thinking. And you can't even, they might be able to change my view, but they won't even open up their mouth about it. They just act like I'm being...
I moved here from Arkansas, and when I was in Arkansas, I was very involved with the home birthing movement and midwives. We had the first lay midwife training program in the country. And I was really 3 of my 4 kids were born at home. So I'm a real advocate, and I came here and I attended a church with a number of young pregnant women, and I started talking about the virtues of natural childbirth. I mean, they'd turn and walk away. It's threatening. I mean, people are scared. They don't understand. They can't get in to see a doctor. They don't want to deal with the big issues. They just want to get their own health care taken care of. Plenty.
Speaking of issues that are, kind of taboo, in these conferences, we never really delve into political discussions, and yet it's like the elephant in the front room.
The elephant.
I mean, is there any realistic, from the medical community, I'm just curious, is there any realistic possibility that Trump will be elected?
Yes.
And if there is there any kind of position that medical human rights groups can take or have taken, and what are they?
I'm not quite sure how you got from Trump to what the human rights groups are doing.
I guess he's my mental image of a violator of human rights.
Oh, okay. Yeah, there are, it's not all black. There are a lot of people in this country working on a lot of different issues. I'm involved with the Jeanette Rankin Peace Center, and where we work a lot on things like the migrant rights and things like that. Specific health care, I don't know, and you're more involved than I am.
I'm not really, but anyway, that was an incredible historical summary, Liz. I never, anyway, it was great.
Thank you.
I guess the question I have has to do with, is arguing about rights really the appropriate approach? Or not appropriate, but I don't think it's sufficient. I mean, I think it's important, but I think one of the things that happens when we start talking about rights is that it ultimately comes down to either public protest movements, which I'm not sure that the current generations are able to do, capable, interested. Yeah. And then the other thing it comes down to is arguing in courts. And I think that lawyers have, I think, one of the lowest, I mean, the general public image of courts, including the Supreme Court, is that it's become so politicized that it's really hard to see a way forward in terms of the going to a court situation. So, and again, I don't have an answer either. I do think that some kind of public movement is important, and I actually totally agree with Clancy that as healthcare providers, we should try and have the conversations, particularly about upstream issues, because when it comes right down to it, what I do for an individual ends up becoming a lot less, I mean, which is again important, and that's what I was trained to do and did for many years, do still. But my role as a community member, and it has the potential anyway for, I can't do things alone, but I can do things within a group. So I don't know, that's a pretty vague thing. With regard to rights and stuff, there's a lot of, I think, positive things in healthcare, which is like the AMA, which I have refused to join my entire career because I thought that they were basically sort of a union for doctors in the bad sense of the word union, but they have actually now come around to to a sense of rights in healthcare. So I'm using that as, at least it took 30 years, and I almost joined them this year, and I decided against it because I'm partially retired and didn't want to pay the fee. Yeah. But there have been a lot of other organizations that, the American College of Physicians, the American Academy of Family Practice, the American, Pediatrics, I forget their American something, Pediatric Academy, yeah. So and even the American College of Surgeons started out opposing healthcare reform and now are not opposing them. So at least as far as groups, sort of mainstream medical groups, there has been progress. It just takes forever. But they might be worth joining. Those are sort of the mainstream ones.
I think actually there's been a lot of progress. As you say, the medical community has recognized now, I think, that certain levels of care really are pretty much a right. We don't always call them a right, but certainly things like emergency care. No decent emergency room doc sends somebody away with a broken leg. That's old history. Used to happen. I mean, I've worked a lot of ERs with docs who would do that. I think the general societal sense is that there is a right to health care, but people don't know how to push it into the systems that will make it happen. We have these horrendous political arguments. I don't think Trump is opposed to people having health care. He's opposed to the government paying for it. That's okay. Let's find another way to get health care paid for. I don't care who pays for it. I just as soon the government did it because it's easier for me to pay a little more in taxes and not have to worry about it. But if there's another way, I'm okay with that. But I think the issue is really a political will one. I think most people agree now, for instance, that when grandma is dying, she has a right to quality care, to have her pain taken care of. I mean, that's not too many years ago, but if you were in pain, terminal cancer, you had to fight to get your pain taken care of. Now they send a nurse out to the house to give you a shot. I mean, that's a huge move forward. The big issues still are, what do you have the right to if you're poor? And we're not looking at the real upstream stuff. We're not feeding kids. All of the relief programs, TANF, all of those things are getting cut. Every year is a battle over school lunches. I mean, how much harm is there in providing lunch to people? I mean, for many of those kids, that is the only meal of the day. And if you've had those meals, they're not exactly what you want your kids eating all day. The food bank sends every Friday, they have a bag of food that they put into the backpack of identified poor kids just to supplement what they're not getting over the weekend. For heaven's sakes, I mean, and I've stuffed those bags fairly regularly, and it's got a lot of sugar, and I mean, it's not really good food, but it's food and it's calories. And, but I think we're making progress. I don't know how to deal with the political thing myself. I'm not active in politics. I've consistently over my lifetime been a work in the streets kind of person and not a politician. What do? We have, 3 electoral votes? What does that do for us? Yeah.
Was initially for single care on an economic basis, and then for political reasons he switched his view. There is a group of physicians for national health program.
Right.
There's some older and younger medical student types that are getting involved in
Yeah.
that. But I just have to comment on this predatory drug pricing that maybe the last 5 or 10 years, it's just gone, even generic drugs now, old drugs that have,
Yeah.
this is just unconscionable. And part of the problem is that we're so reliant on prescribing drugs.
Yeah.
That's a go-to quick, and they know it, and they're going to just make whatever they can on it.
And most people, and I think, addressing rights is a good thing. A lot of it is an education thing. Most people don't understand about the cost of their drugs. They don't understand the doctor writes a prescription for some brand new diuretic, let's say. Hydrochlorothiazide is still $6 for 3 months or $9 for 3 months, and it works fine. People have to be educated about how to get the most out of their healthcare dollars. But it's the upstream thing too, or downstream, I don't know where it is. This incredible amount of money that we spend on healthcare in this country for very little return. That's the dialogue I think that has to happen. What are the things that we really need to be paying for? We also don't need to be building up the military. I mean, let's put some of that money into feeding children. I mean, it's not just healthcare. It's the whole American dialogue about politics. I don't have any answers. Yeah.
I was curious to hear your opinion, I guess, on how necessary you think certain divisions of healthcare are. Maybe, improving the already well with such practices as, plastic surgery and human enhancement. Should there be, a rationing of how much we, give to that, or?
You're not going to like my answer. If you want breast augmentation, I think you need to pay.
No, yeah, I agree with that.
I don't care. If the doc wants to do it, that's cool.
No.
No.
And I guess what I'm mainly thinking of is it seems like some doctors are, going into those practices, and it's a very competitive, field of medicine. And I feel like, should there be some sort of, I don't know, yeah, something like that.
How many of you are physicians? You know the story. Um, medical literature's replete with it now. That doctors, many doctors, not all doctors by any means, but many doctors, for whatever reason, are in it for the money. And you can't fault them. They're coming out of medical school with these huge debts. In many, I think the Cuban system, we hold it up as being so super, and there are a lot of problems with it. But those docs, every one of them, has to go to a developing country, or Cuba, I mean, they can work in Cuba. They have to do a couple of years of service before they are allowed to start practicing in Cuba. I worked with a really nice young Cuban doc in Honduras, and he was dynamite, and they were killing him. I mean, it was hard work in this little town we were in. He loved it. We got together for dinner one night, and he was happy as a clam. He was getting out. I mean, he knew there was an end in sight. But a lot of folks who go and do that work, I did. I had a private practice for a little while. I said, I don't need to do this anymore. I'm going to go and see if I can find some people to take care of me. And, most docs are, I think, are good-hearted, but there's a lot of them now that are thrown into it. And no question that plastic surgery, if you're good at it, is big money. Although if you look at the statistics for the doctors that make the most money, the top of the list is dermatology. And it makes sense. And when you get to my age and you start having to go to the dermatologist, they charge exorbitant amounts to take out their little liquid nitrogen gun and shoot your keratosis. And it's allowed. I mean, it's the official number, or the RSV for that procedure is hundreds of dollars. It's craziness. But that's the only thing I can say. I think most docs, certainly in a place like Montana, you don't practice here if you want to get rich. I turned down a job in California a couple of weeks ago, and they were going to pay me $250 an hour. I don't get 100 here. I mean, it's. Other comments? Yeah.
With regards to that, do you think some of it is, our system promotes for docs to see patients now in 5 minutes and to bring in this many work reviews in a day, and if they're not reaching that many work reviews in a month, or they're at the 60th percentile, then they're criticized for it?
Yeah, you don't want to start me on that subject.
Okay.
I mean, my basic training was in internal medicine, and I can't do a new patient intake in less than an hour. And my internist here got half an hour to see me, and we're still playing catch up. We're sort of guessing at what that symptom means. And, I think it's inexcusable. But you have people like Ann who are really dedicated to taking care of their patients. But when her patient goes in the hospital, she's going to lose. Medicare is going to pay you now to talk to your doctor about end-of-life wishes. If you are hospitalized, the odds of your primary care physician, even knowing you're in the hospital, let alone that you're dying, is pretty poor. And there are all kinds of disconnects in our system, and that's one of them. That docs are being held to time schedules now.
But I think as a patient, you're going in, like you're maybe 2 months out, you get in, you're there for 5 minutes, you have your notes of, and you try to get through I'm in healthcare, so it's like everything I want to discuss, and I still don't feel like I can even reach that point.
Yeah, I have a couple of docs that I think are really good. I'm never satisfied when I leave the office.
And I know they're pushed
oh, both of them are trying to retire. And that's the other thing that really is scary. All of the docs that I know over about 55 are trying to figure out how to get out. And we have this healthcare resource shortage as it is. And I'll grant you some of the young guys know a lot more than I do, but the years of practice and experience are worth a lot. And I don't know what's going to happen. We're all gone. Somebody else has a microphone. Yeah.
I don't know if we want to stop. Somebody hand me the microphone. We're over time. But
Okay.
I guess the comment I was going to make is, I mean, I'd maybe push back a little bit. I don't think
No,
it's as bleak as you paint in this country about us not having sort of insured rights. I mean, we've decided that whole groups of people have pretty good access to health care that we are providing publicly. I mean,
Oh,
I think
it's definitely gotten better.
we've made a lot of progress. We have
Yeah.
a long way to go. But the question, what I'm wondering about is I feel like we struggle a lot, and maybe a lot of the other countries do too, with sort of the stewardship of that right on both the provider side and the patient side, or whatever terms you want to use, the system side and the public side. And I'm wondering if you have any comment about how other places that are maybe a little bit more evolved on this have negotiated that, and whether it's the example of the patient on, Medicare or, other public programs, showing up at the ER for a minor symptom when they could have accessed care more appropriately. Or, my most recent favorite example was a very wealthy elderly couple, retired physician and his spouse, recently admitted at this hospital. The wife is on Medicare, had a stroke, came in, was cared for. They got excellent care. They had some learners involved in their care while they were here in the hospital. And there was a comment about, well, those learners on the team really need to be informed about, the expectations that people have when they come to a private hospital. And, there's still this mentality all around that, this is mine and I can do whatever I want. And, I think on the provider side too, there's really still not a lot of restriction to us, ordering whatever medications and tests and things that we want. And, sort of stewardship of that collective right is not a prominent part of the conversation.
I think everything you say is right. Except there's always the human side to it. When I worked ERs, the nurses were always amazed because if somebody came in the middle of the night with a back pain or something, I would just, that's fine, I'll take care of them. I found when I talked to those people, there was a reason they were there. It wasn't because their back hurt. It was because their husband was going to beat them, or or something was going on at home, or they couldn't get in to see their own doctor, and that's always an issue, of course. I do think that, again, it's an education issue. Back when families were close together and there was a grandmother who could look at the baby and say, oh, he'll be fine, let's wait till tomorrow morning. That doesn't happen anymore. Young parents get scared. People who say they want to take care of their dying relatives really don't know what they're getting into and often panic in the middle of the night. But certainly people go to the doctor for reasons that they absolutely don't need to go to the doctor for. They say that 95% of family practice patients, office patients, will get well fine without seeing the doctor. I think that's probably pretty close to right. And that, you got to think about that. Well, how do you? And a lot of practices are addressing it. You're right. I'm kind of a doomsday person, but actually, I'm not. People say, "Are you half full, half empty glass?" I say, "No, it's an 8-ounce glass, and there's 4 ounces in it." But a lot of practices are beginning to address this. They have nutritionists, or they have social work. A lot of things like partnership have a lot of services to help people get their needs met. But when money's driving the thing, and those are not reimbursable services, you have a problem. My son's wife just had a baby in the Kaiser system, and I was really impressed. They got an incredible amount of care, and very little of it with an obstetrical person. They had lactation specialists and nutrition specialists, and it was very impressive. Well, I guess I can't melt this for any more oven.